So thank you, Bernard, for meeting me. So today we're going to be talking about pharmacare, which is an issue that's important for all Canadians, but specifically we'll be focusing today on Ontario. And for those who don't know, so Dr. Bernard Ho is a family and emergency physician currently working in Toronto and one of the policy advocates with Canadian Doctors for Medicare. So thank you so much for speaking with me today.
Thank you so much for having me.
You've been advocating on the importance of pharmacare for a very long time. Can you tell us a little bit about why this became such an important issue for you as both a frontline physician and a policy advocate?
Yeah, sure. I mean, as you said, I'm a family doc and an emerge doc, so I'm on the front lines of our healthcare system. So I really see the consequences of poor health policy and poor public policy and my patients and in society writ large. So I see the downstream effects of a lack of pharmacare because medications only work if people can actually afford to pay for them. So it doesn't really make sense that we insure doctors and hospital services, and we diagnose people in hospitals and in clinics and give them a prescription to take medications, but we don't actually help them pay for those medications. And this leads to a lot of cost-related non-adherence. It leads to worse outcomes, leads to higher downstream costs in the emerge and in the hospitals. And I mean, historically, pharmacare was meant to be a part of our Medicare system. It was just implemented in stages. So firstly, with our universal hospital insurance, and then medical insurance, and then pharmacare was supposed to be the next step. It just never happened for political reasons. But over these last 50 to 60 years, numerous reports have come out advocating for a national pharmacare program. So like the Hall Commission, or the most recent advisory council report. Several other reports also really advocated for a national pharmacare program. So it really doesn't make sense that we don't include prescription medications in our universal healthcare coverage.
I feel the exact same. I think like you, as a physician, it always felt so nonsensical that, the visit with us is covered, the visit to the hospital is covered. If someone needs diagnostic testing, that's covered. But the only piece that isn't covered is often the component that could reduce the need for so many of those other things, right? If we had people who had access to their medications, they wouldn't need to see their doctors so often. They wouldn't have, preventable complications of chronic disease. So it really does feel like this one piece of the puzzle that's missing that doesn't make any sense. Could you outline for us, like, where are the gaps right now in Ontario? Who is covered and who is not?
Sure. So our Ontario's healthcare or public plans for prescription medications are sort of a patchwork plan. So ODB, or the Ontario Drug Benefit, covers most people over 65, residents of long-term care homes, or recipients of Ontario Works or ODSP. But many of these people still have to pay copays or deductibles unless they qualify for the seniors copayment program. OHIP Plus is eligible for people under the age of 24 only if they don't have a private plan. So anyone under the age of 24 with a private plan is still excluded. The Trillium Drug Program is available for catastrophic drug costs, but there's still an annual deductible, which is about 4% of household net income, which is still a barrier for middle income and low income families, those from lower socioeconomic backgrounds. And then the federal program covers some specific groups. So the IFHP covers refugees, refugee claimants, and then there is a federal program for First Nations populations as well. So many, many people still left out. Anyone between the ages of 25 to 64 don't have full coverage of prescription medications. They require on workplace benefits or other private plans. And there are still high deductibles and copays. So a significant proportion of people in Ontario are still left out of these plans.
Yeah, and I think the most recent data that I saw was, even for folks who are working, still about 1 in 5 don't have any access to any drug coverage, public or private. So there's a lot of people who are working full time or maybe are working part time but still aren't covered. And I think that impacts a lot of gig workers, a lot of people sort of in more informal employment. So like you said, it's really a huge portion of our population that doesn't have consistent coverage for medications. Um, and we've heard a lot recently about the federal pharmacare commitments, and those were focused on access to contraception and diabetes medications, which still would have been a huge advance from where we were before. Can you tell us a little bit about the federal pharmacare commitments, kind of why those two medication classes were chosen, and what it could mean for Ontario if we were to sign on?
Yeah, I mean, it's definitely a historic moment. I'm not privy to the decision making between why or behind why those two medication classes were chosen. We had advocated for a much larger class of medic or group of medications classes to be chosen rather than just two. But this was a decision made by the previous Minister of Health. And the way that the federal pharmacare plan or program they've chosen to implement it is to have the provinces sign bilateral agreements with the federal government to fund first dollar coverage of these medications. So if Ontario decides to sign a bilateral agreement with the federal government, Ontarians would see out-of-pocket costs for contraceptive and diabetic drugs drop to $0 with the federal dollars help fund it. But so far, we haven't seen any political will from the Ontario government to sign on to this bilateral agreement, which is unfortunate. It leaves Ontarians paying the costs of these medications. It means Ontario is leaving money and health gains at the table. And it unfortunately means that we can't have federal cost sharing plus the sort of national purchasing leverage to lower drug prices and to be able to expand the classes of medications afterwards. So it's really a missed opportunity for our province to sign on to this bilateral agreement.
Yeah, and based on what I've seen from the other provinces that have signed on, if Ontario were to get a similar funding agreement, it is really billions of dollars that would be influxed into our system. So we're right now leaving billions of dollars essentially on the table and not using that to be able to boost our healthcare system and to offload the cost for patients, but also offload that cost within our public system as well. Um, and we also have heard sort of the federal government, maybe signal that they might be backtracking on that, that we don't know if there's going to be this opportunity to sign on an ongoing basis. If we're not going to be able to see a lot of progress on pharmacare at the federal level from here on out, what do you see as some tangible steps that the Ontario government could take, the things that are sort of within their control to be able to improve access to prescription medication to folks?
Yeah, I think Ontario should still try and signal that they would be willing to sign on to a bilateral agreement. That would help put pressure on the federal government to continue with this pharmacare program. And also, Ontario has a lot of power or influence within the country. And so, if Ontario signed on, it would also help build that momentum to put some more pressure on the other provinces and territories to sign on too. Other ways that Ontario could help expand our pharmacare program, expanding OHIP Plus to include or encompass a larger range of Ontarians, lowering the deductible for the trillion catastrophic drug coverage from less than 4% to maybe around 2% of net income. Um, Potentially fast tracking a provincial deal that sort of mirrors the federal government's plan. So including contraceptive medications and diabetic medications within an Ontario specific plan, while the negotiations continue so that patients don't have to wait or Ontarians don't have to wait for the bilateral agreement to be signed. Ontario could also adopt an essential medication list for first dollar coverage to start with high value primary care medications. So blood pressure medications, cholesterol medications, diabetic medications, and many others that we see quite often in primary care and family doctors' clinics.
And by the most recent data that I've seen are estimations or projections of what that would cost us, even if we were just to add on an essential medicines list for Ontario for all Ontarians, it would cost us about 1.3 billion, but it would save us about 2.1 billion. Would you mind just like expanding as to where those savings come from? Like where are we generally seeing the cost in the system right now because of the lack of access to those medications?
For sure. So, I mean, a system-wide savings happens because of bulk purchasing and lower administrative costs. And so there's several studies that have come out looking at the cost of a national pharmacare program. So the Advisory Council estimated about $5 billion a year in overall savings. Again, because of bulk purchasing and lower admin costs. The parliamentary budget officer also estimated about a 1.4 to 2.2 billion dollar savings over the first few years. And this doesn't even count the savings that we would see from downstream effects of a pharmacare program. So, as I alluded to earlier, when patients are healthier, there are less ER visits, there are less hospitalizations, there are less unnecessary procedures or surgeries. Patients are able to afford their medication, so they're able to take them, and leads them to a healthier society. And so all of those savings are hard to quantify, but are definitely significant in the long run. So having a national pharmacare program would create savings not just in the short term, but also very much so in the long term.
Absolutely. And can you think of any examples, maybe just to illustrate the impact, like from your perspective as an emergency doc or as a family doc? What's the impact on your patients in terms of not being able to afford their medications? What kind of negative outcomes have you seen?
Yeah, for sure. So when patients can't afford their medications, they have to, make decisions to try and prolong their prescription. So they either cut their medications in half, they take them every other day, they delay refilling the prescriptions as long as they can, or they have to choose between their medications or groceries or their rent or other necessities. And we know from a survey done by Angus Reid a few years ago that about 1 in 5 Canadians do some of these extreme measures to try and prolong their prescription medications. And I can think of several patients that I've seen in the emergency department who've I've seen the consequences of a lack of a pharmacare program. There's a patient that I know quite well who used to come in quite often because of he had congestive heart failure, but he wasn't able to afford the several medications that he was on for his CHF. And so he used to come in with CHF exacerbations quite often. But they kept getting worse and worse and worse because he wasn't taking his medications on a regular basis or sometimes not at all. And unfortunately, the last time I saw him, his exacerbation was quite severe, and he needed to be admitted to the ICU. He needed to be intubated. And I'm not 100% sure what happened, but I haven't seen him since.
Mm.
But these are real people, real Ontarians who deserve good health care. They deserve to be able to afford their medications, and it has real life consequences, the lack of political will that we're seeing so far.
Yeah, and I think, the fact that people aren't able to access the things that would keep them healthy, that would keep them able to do all the other things that they need to do in their life, right? Care for their family members, care for their neighbors, go to work, contribute in any number of ways to the community around them. I think there's such a human cost to it. And then, like you said, there is the systems cost too. So even if we just focused on the dollars and cents of it, that patient coming into the emergency department needing to be hospitalized, usually for several days, for CHF exacerbations to be managed, is at minimum $1,000 a day if you're in a regular ward bed. And then when you talk about ICU level care, like he was experiencing, that's multi-thousands of dollars per day. Um, and the fact that we could easily exchange those dollars just for paying for that person's medications, to keep them out of hospital and to keep them well, it really, I think it's, yeah, not only the right thing to do, I think morally and ethically as healthcare providers, but also um, from a fiscal perspective, the case seems quite clear cut. What do you see as sort of the main barriers as to why we haven't moved this forward over the last several years that you've been advocating?
Yeah, I mean, I think it's lack of political will, and it's the potential upfront costs that I see governments are quite afraid to take on. But I think unfortunately it's quite short term to look only at the upfront costs without looking at the savings both in the short term and in the long term that we talked about. It's also quite unfortunate that that our governments aren't looking at as you said, the people behind this, the Ontarians and the Canadians who are suffering because they don't have access to affordable prescription medications. As you said, it increases our ER visits, our hospitalizations, it worsens outcomes for patients, leads to significant downstream effects. So I really hope that we see political will from our province and from our country in really moving this forward. This is a historic piece of legislation, and again, it was meant to be passed decades ago.
Mhm.
We just haven't really seen that political will yet.
Yeah, so it's really just fulfilling that promise of what universal healthcare should look like, but we just haven't really realized despite decades of trying to get there. Um, and the thing that also strikes me is that there are very few policy changes that we could make that have such wide-ranging public approval. I believe it's about 86% of Canadians, when surveyed, are in support of expanding access to pharmacare. Is that sort of consistent with what you've been seeing when you look at sort of public support for these initiatives?
Yeah, 100%. And that's as you said, it's quite rare. I mean, it makes sense though, right? The high cost medications affects everyone across the political spectrum. It doesn't really matter, what your political leanings are or how you vote. Most people need to be on medications at some point in their life, and it does, those costs do add up. So really, there's this bipartisan support from Ontarians and Canadians for a national pharmacare program. And so I'm really hoping that Ontario and Canada sees this as an opportunity to really push this legislation forward,
Yeah.
and to improve the lives of everyone who would be affected.
Absolutely. And I think the other piece too is that there are many people, like you said, who are within that group, that age group, that 25 to 64, who don't have any public coverage, but might have private coverage right now through their work. And so maybe this doesn't feel as acute of a need because they have medication coverage. But could we talk a little bit about what it would mean for workers if medication coverage was actually taken in within the public domain? And unions and other workplaces didn't have to bargain for drug coverage as part of its, collective bargaining efforts. Um, what does it cost us for so many people to be covered by private plans versus public?
For sure, because there are so many private plans and because it's so piecemeal, it means that our bargaining power is much weaker and we're not able to purchase drugs at a lower cost because there are hundreds of thousands of different private plans in Ontario and in Canada. It would also, if we had a pharmacare program, it would also alleviate the burden on workers to find the best private plan, or on people under the age of or between the age of 24 to 65 to find the best private plan. It would mean that all of these medications are completely covered at the very first dollar. So there's no copay, there's no deductible. They would have peace of mind to know that if they needed these medications, they could just pick it up at zero cost, at $0. And again, a big part of that is because of the better bulk purchasing that we're able to do because we're bargaining for all of Ontarians and all of Canadians now, as opposed to just a few workers and working in a company. So it makes more sense, makes the most sense, as you said, fiscally, to do this, and it makes sense from a health policy and from a social policy perspective too.
Awesome. Thanks so much, Bernard. I really appreciate you taking the time to talk about this.
Thank you so much for having me.
Of course.